Alrighty. Welcome to our 67th virtual shadowing session. My name is Taylor, and tonight we have for you a presentation on emergency orthopedics with Dr. Dustin Harris. Next slide, please. As always, we have our working group, which includes our 4 physicians, Dr. Fowler, Dr. Salazar, Dr. Marchetti, and Dr. Reno. Next slide. And then just to let you guys know, next week we have a specialty spotlight in maternal fetal medicine. And then on the 14th, we have a specialty spotlight in trauma and acute care surgery, followed by getting into medical school 101 on the 21st. So be sure to show up. And then just a reminder, we're going to have our Q&A at the middle and end of the presentation. So be sure to put all your questions in the chat as we go so we can get them answered. And that being said, I'm going to let Dr. Fowler introduce our special guest.
I want to welcome everybody. Thank you for coming to our 67th session. I hope my internet connection is cooperating, and if it isn't, I apologize. We're so glad to have you. 15 months now that we've been doing this. The admissions committee season is starting for medical school anyway, and we're beginning to see that admissions committees are paying attention to virtual shadowing hours. So please come. And please enter these into your application. We think they will help you in your search for a career in medicine, whether it's med school, PA school, nursing practitioner school, or other parts of careers. We're going to be here as long as you keep coming back. Tonight we have almost 200, and we're delighted to continue to be a part of your preparations for your career in healthcare. So please keep coming back. Please spread the word. We'll keep communicating with you via the various methods, including our email service, Instagram, and so forth. Tonight, go ahead and do the next slide, Dustin. Tonight, we are absolutely delighted. Was that your cover slide? Okay. Tonight, we are absolutely delighted to welcome one of our colleagues, Dustin. He's going to introduce himself in a moment. Part of our Department of Emergency Medicine at UT Southwestern Medical Center, Clemens University Hospital, and the busiest emergency department in the United States, which means the world, Parkland Memorial Hospital, which is our practice home. So Dustin, why don't you take it away?
Hey everybody, I'm Dr. Dustin Harris. It's nice to meet you all. Hopefully you all can hear me pretty well. I really want to encourage questions with this presentation. Some of the terms I use, some of the pictures may inspire lots of questions. I'm happy to explain anything that I cover. I know that this talk is sports medicine and emergency orthopedics. There's going to be some good pictures coming up. So the first half of the talk, I'm going to talk about how I went into sports medicine. And then the second half, we're going to go over some emergency orthopedics cases. I didn't really cover this in my slides, so I'll cover it very quickly. So emergency medicine is my primary specialty. It's currently 100% of my time. I probably work about a job and a half right now. But I chose emergency medicine after a crazy night in the emergency room during my first year of medical school. I got to see someone who sustained a gunshot wound to the chest. We did an open thoracotomy where you crack open the chest, spread the ribs, and expose the heart. And I was able to place my hands on the heart and try and manually beat it until it was shocked back and the person came back to life and went to the operating room. And I thought, this is a specialty for me. Emergency medicine is great because it's shift work. The hours it can be anytime you get a night shift. You see some crazier things. You can work during the days if you prefer, during middays. But when you're there, you're there. When you're off, you're off. But sports medicine offers different things for me. So I'm going to talk about how to become a sports medicine physician, the different careers that could be available in sports medicine. Some may surprise you. And then we're going to go into emergency orthopedics. All right, so what is sports medicine? So a lot of patients or just even friends and family will ask me, what is sports medicine? Do I need to be an athlete to come see you in your clinic? And that is not true. So another way I describe it is non-operative orthopedics. So orthopedic surgeons do a lot of great surgeries, but not, I would say the majority of MSK or musculoskeletal injuries or complaints or illnesses aren't fixed by surgery, or people don't even want surgery because surgery can come with its own risks. So I offer kind of alternatives to actually getting surgery for certain injuries and illnesses in MSK pathology. So I treat athletes, but also You can be treating weekend warriors. They don't have to be a professional athlete to come see me. Just someone who's trying to get back into shape, running on the weekends, or someone who used to be an athlete in the past. And man, I had a bad injury and I never really got it checked out. And now it's really bothering me now that I'm in my 40s, 50s, 60s. But I would say the majority of what I see is actually arthritis, because our baby boomer generation is now getting older and experiencing arthritis. And actually arthritis is probably one of my favorite things to see, because I have some very good treatments for arthritis. Once the patient feels better, they get back to running, swimming, or whatever their sport or exercise of choice is. One of the previous jobs I was offered, which I'll talk about later, is, you talk about workplace injuries. So bad posture when you're sitting at your desk can lead to chronic back pain, or you can be, a lot of people are working at Amazon these days. Amazon is booming during the pandemic. Lots of heavy lifting packages, can drop things, run into things. So some of the doctors I worked with were doing a lot of workers' compensation, getting their surgeries or treatments covered by workers' comp. A lot of fractures don't need surgery. I had several fractures growing up, and always have to get an operation or get a plate or a nail placed by an orthopedic surgeon. You can let it heal just with time, and all I have to do is just repeat x-rays, make sure the bone is healing well and that no complications are occurring. Strains and sprains. So a good way for me to remember strains versus sprains. So strains has a T in it, so that involves the tendon. So tendon attaches muscle to bone, and a sprain is ligaments, and that attaches bone to bone. That'll probably be it's not on the quiz today, but it might be on a test later in your life. Now, how to get into sports medicine. So first, you got to get into medical school. So some people out there, maybe you're already in medical school, congratulations. Some are applying, good luck. And then some are just thinking about it. And I would encourage you to do it if being a doctor is what you want to be when you grow up. So first you go to medical school. Then you have to complete a specific residency to do sports medicine or non-operative orthopedics. And currently these are the specialties you can do: either emergency medicine, internal medicine, family medicine, physical medicine, rehabilitation, and pediatrics. It doesn't matter which one you do. I was actually discussing with a resident last night, kind of, if you want to do sports medicine, which one should you start with? Well, I personally love emergency medicine, so I had to do emergency medicine first. I didn't even know I wanted to do sports medicine until probably 6 months into my emergency medicine residency. But if you prefer to be kind of a primary care physician treating hypertension, diabetes, well child checks, you could do family medicine. If you prefer to work specifically with kids, you could do pediatrics. And physical medicine rehabilitation, sometimes people don't really know what that is, but they deal with a lot of chronic pain or nerve injuries, and they do sometimes nerve injections or blocks, which is really cool for them. But the training is overall very similar depending on what route you go. But at the end, kind of the final board exam is all the same, no matter what you do. And then you apply for fellowship. So residency is your initial specialty in medicine, and then fellowship is kind of a subspecialty. So you kind of apply for it again, just like you're applying for medical school, just like you're applying for residency. Kind of your test scores don't really matter. At that point, it's kind of more your application. What have you shown to show your interest in sports medicine? So when I was in emergency medicine residency, I actually volunteered with the high school team that was in the south side of Chicago. Didn't have many resources, but they were actually very good. And I'd volunteer, be their team physician once every couple of weeks. And I learned a lot from them, especially about concussions, which we won't have much time to talk about with today. But most sports medicine fellowships are 1 year. I know the UCLA fellowship does offer a 2-year option, which entails more research. I'm not sure if more programs are going to go to 2 years. There's been some discussion. I think maybe in the future, sports medicine may be its own specialty, maybe incorporating all of family medicine, PM&R, emergency medicine, all into that one residency, but that doesn't exist quite yet. And then I'll go into the specifics of what I did during my fellowship. So I kind of alluded to, so I went to UCLA for medical school, and then I completed my residency in emergency medicine 3 years at University of Chicago, and then I went to Stanford for my sports medicine fellowship. This is a picture of me during my emergency medicine residency. It was a lot of fun. Probably the most fun I had was flying in a helicopter with flight nurse as well as a pilot. I wasn't flying the helicopter myself, and we pick up patients from other hospitals and transport them. And then I'm sure Dr. Fowler and Dr. Marchetti are very familiar with that process.
Well, Dustin, you look like you're doing an EMS fellowship there, honestly.
Exactly. It was a lot of fun. It was kind of hard not to choose a lifestyle where I got to fly in helicopters more often, but sometimes we can get a little seasick or airsick up there. All right, so this is me during my fellowship. It looks like I'm working very hard. So my specific fellowship is not equal to all other fellowships, but I'm just going to tell you how mine was. So my fellowship included 4 clinic days a week. Now that clinic could be in multiple different specialties. I would go to orthopedic surgery maybe once a week or twice a week, probably for a half day. Although I wasn't doing surgery, 2 great benefits of going to orthopedic surgery was, again, getting better familiar with the anatomy in orthopedics and non-operative sports medicine. Also, orthopedic physicians do a lot of injections in the OR prior or after their surgeries to help promote healing or to decrease pain, and they would let me do that in the operating room with them. Podiatry, very underutilized specialty. They would say the feet are the gateway to the body. I think they're very important. I personally am not a feet guy, but some people are. So I would do a couple of days in podiatry clinic. They're very, very, very smart, almost like cobblers making shoes for people to help with sometimes people have back pain because they actually have foot issues. So they kind of have to work on the biomechanics, which brings me into physical therapy. So I'd go to physical therapy probably twice a week and watch what they do, help with some of their evaluations. And I think also physical therapy is underutilized. Probably at least half the patients I would see in the clinic, I would refer to physical therapy because I don't have to put a needle on your knee or your shoulder to help. Not a lot I can do in the clinic will fix what's going on. You sustained an injury or you're having pain for, a multitude of reasons. And that one of those reasons could be biomechanics, or did you have bad biomechanics and that's why you sustained an ACL injury, or do you have bad posture, or are you not doing your squats right and that's causing you to have, knee pain or back pain, or, your rotator cuff, your scapulas are moving incorrectly, or they're kind of uneven because you're right-handed versus left-handed. And physical therapists are fantastic at kind of finding out what is the problem, what caused the problem. And so not only will they help you with therapy, but they'll also give you exercises to do on your own, even after the therapy finishes. So I love physical therapy, or referring to patients to physical therapy as well. Now it's kind of required through the Accreditation Council of Graduate Medical Education that you still practice your primary specialty during your fellowship. Now, what does that mean? So I was an emergency medicine physician, so I had to do 4 hours of emergency medicine a week. It's kind of hard to do a 4-hour emergency room shift. You can ask Dr. Fowler or Dr. Marchetti, but so I would do weekly ER shifts. And then even in my spare time, I would pick up shifts at an outside ER to make extra money, but also challenge myself. So that's something that's very important for anyone thinking about, going to fellowship one day. Try to look into programs that will let you still do your primary specialty, because you don't want to get kind of rusty when you're doing a second specialty. There was a lot of sports coverage. So we would do lots of football because that is probably the sport with the highest number of injuries. I would cover high school football, junior college football, and Division I football. And so some of my weekends would be jam-packed with lots of games. And so the beginning fall season is very busy for sports medicine. Then after that, it kind of tapers off. There's a couple swim meets, track meets. Wrestling can also have a lot of injuries. They have a lot of rashes as well, which isn't my favorite thing, but they can be very dangerous if they go untreated. And so weekends are kind of tough during the first half of the fellowship because of a lot of football coverage. But I had great injuries, lots of concussions. We had an elbow dislocation, and during one of my junior varsity high school games, we had a hip dislocation, which I thought it was fractured. So I actually sent the patient to the emergency department, which I'm glad I did. And then actually during an Ironman we had 2 shoulder dislocations, which was pretty interesting and very fun to put back into their socket. Now elective. So this is me on my elective. We had a Tahoe ski elective where we would go to a clinic at the bottom of a mountain. This was in Squaw Valley. So anyone who has been skiing or snowboarding had the privilege. There's usually a clinic associated or hospital close by in case someone gets injured, because this is a high-speed sport that can get a lot of bad injuries. So we were actually a clinic on the mountain, and the ski patrol would bring patients down to us. There were a lot of fractures, a lot of dislocations. It was a ton of fun. So I was there for a month, and I would snowboard in the morning and then put people's shoulders back in the afternoon. So during my fellowship, maybe the second half of it, or third quarter of it, COVID cases were rising. So this is what I had planned during my elective time. Besides the ski clinic, I had planned to volunteer at the U.S. Olympic Training Center. You kind of have to do some sort of Olympic training volunteering before you become an Olympic doctor. You also need several years of experience before you become an Olympic doctor, but I want to get that out of the way. So I was already slated to go there, and they accepted me and everything. So I was going to volunteer and work in their clinic, especially being an Olympic year. I was excited to do that, but couldn't do it, unfortunately. And then there were several conferences I was going to be a part of, as well as large races. There was a race, an ultra marathon in Zion that I was going to help work. And I was going to go to like an ultrasound conference in San Diego. So they do give you a lot of free time to kind of explore your specialty and kind of look into more what you're specifically interested in. And I really liked it, ultrasound, and also large event coverage. All right. So what do I actually do in the clinic? So first, I want to try to diagnose what's going on. So I became very good at diagnosing with musculoskeletal ultrasound. Some studies show that actually ultrasound can be just as good as MRI when used in shoulders and sometimes knees. Specifically in the shoulder, it's a very difficult ultrasound, but if you can find what's going on, you can save them time and money by diagnosing them just at the bedside, rather than when you're in the ER, you have everything there for you. You have all of your imaging, and it's read right then, and it comes back before the patient leaves. In the clinic setting, you have to order the MRI. They have to go there. They may not go there that day. Then you have to follow up the results. You have to call the patient back in to discuss the results, or you could discuss it over messaging, but you can't really treat them until they come back to the clinic. So it actually helps if you can diagnose it right there with the ultrasound, whether it's a strain or a sprain, or they have a hematoma that needs to be drained, or they just have fluid in their joint from bad arthritis. You can diagnose it, and then you could do treatment. So you could refer them to physical therapy, or you can do what's favorite of mine is injections. So a very common thing that we do is steroid injections, and probably some of you have heard of it, like a cortisone injection. Steroid injections are great. I wouldn't put them in a ligament or a tendon, because it actually could degrade it down. But that actually happens in joints as well. So if someone has bad arthritis and they just have too much pain and they can't go to their physical therapy because of pain, steroid injections can really help. It'll decrease inflammation. But too many injections can cause degradation of the joint, and sometimes it's kind of a risk benefit. You have to weigh them against each other and see what the patient wants and what's best for them. So another option is synthetic joint fluid, also called viscosupplementation. There are many companies out there that do fluid, that create the fluid. Some of you might find this interesting. Actually, the hock of roosters, that contains a lot of hyaluronic acid, and that is used to actually make some of the joint fluids. You can put that into the joint, and it can increase the kind of cushion between the two bones that are rubbing against each other and causing a lot of pain and arthritis. An injection I did a lot in my fellowship, and I plan to do a lot here, is PRP, or platelet-rich plasma. So you are drawing the patient's blood, you put it in a centrifuge, spin it down, and then you take off the plasma, which includes platelets and also growth factors. Two sites that have been shown to really benefit from it are through randomized controlled trials, for those of you familiar with research, is lateral epicondylitis or tennis elbow, or knee arthritis. But there is hardly any downside to the platelet-rich plasma injections. I'm sorry. There is hardly any downside. So the only downside is sometimes insurance doesn't cover it. So the cost could be several $100s, which a lot of patients can't afford. So you have to also go into that. Steroid injections are usually covered. You could do stem cell injections, which are very expensive, but some people want the best, and the stem cells can come from your own fat. They can come from bone marrow. They can come from fetal tissue, any of those. And there's also dextrose injections, which is more of a sclerosing agent, which can, let's say there's a nerve that is kind of getting entrapped between two structures. You can encircle it in dextrose and kind of tack it down. Some people will do, it's called like prolotherapy. The shockwave, which is kind of how it sounds, you could use either vibrations or actual kind of small electric pulses to go over trigger points in patients, which is very popular in Europe and Germany. Lots of research studies coming out about that. And then when you apply to medical school, you can choose either to go the MD or DO route. If you choose to be a doctor of osteopathic medicine, they do OMM, or osteopathic manipulative medicine. I'm not familiar with that, but a lot of the attendings that I worked with during my fellowship were DO trained, and they would do some manipulations to patients. So if you are interested in something like that, very hands-on, I would probably look into that more if you want to consider going into a DO program. Careers. So you could be a clinic doctor, which I am trying to do that part-time for my emergency medicine job. So mine's more academic, but you could have your own private practice, which we'll get into in a second. You could be a team physician, which I do for a high school, but you could be a college doctor, team physician. You could be a team physician for an Olympic team. You could be a professional team physician. FYI, NHL teams and NFL teams, they require an emergency medicine physician at their sideline in all their games, which a lot of the EMS personnel at my hospital, they work with the Dallas Stars because they're an NHL team, and there can be a lot of bad injuries, and the emergency medicine physician will know how to secure an airway if there's any airway injuries. Same thing with the NFL team. Sometimes they require a neurosurgeon, sometimes they require orthopedic surgeons there to be there as well. So you don't really need a sports medicine fellowship to be a sideline physician. You need to do either orthopedic surgery, emergency medicine, sometimes anesthesia is there, sometimes neurosurgery. But if you're like a day-to-day physician, you want to be the person that examines them in the training room, prescribes medications for them, goes with them on trips. That's a team physician, requires more time. It's a full-time job. Olympics just happened. I think Paralympics are currently happening. You could be a team physician for them. And then Facebook physician, this is kind of a funny story. So before I left the Bay Area, I was applying for jobs, and I was currently applying for this job as well as applying for a job in jobs in California. And a recruiter reached out to me and asked me if I wanted to do sports medicine for Facebook. Now, what does that mean? So Facebook and a lot of other tech companies have clinics on their campuses that are kind of all inclusive. So they'll have your primary doc, they'll have a sports medicine physician, they'll have physical therapy, they'll have your optometrist, dermatology, acupuncture, that kind of stuff. And so they wanted a sports medicine physician because I'm sure a lot of their employees are active and get back pain or carpal tunnel syndrome. So they actually hired me, but I never started because I came for this job, and this job is definitely more exciting than back pain and carpal tunnel syndrome. These are just a couple of the people that I've met through my journeys through emergency medicine and sports medicine. This is Dr. Tom Mayer. He's only trained in emergency medicine, but he's very, very experienced and very high up. But he's the medical director for the NFL Players Association. And so he's been very impactful with like concussion treatments and protocols for NFL players. And so he's kind of the liaison and kind of helps the players kind of return to play and kind of decides like we need an ER physician at the sideline at every game for these reasons. And they listen to him and take that into account. There's Dr. Leroy Sims. He's one of the people that was kind of in charge of the bubble when the NBA season was happening during COVID. And so he was previously at Stanford. I think he probably still lives in the Bay Area. He used to work with the USA track and field. He has a track and field background, but he's a good friend and mentor of mine. And yeah, this is Dr. Provo, Jace Provo. He is more of the, he was previously with the NBA for many years. He actually graduated from my emergency medicine residency back in the day. And he does like all private practice, kind of cash pay, urgent orthopedics. He does a lot of stem cell injections. Sometimes he'll harvest his own stem cells. So he'll give you like a little bit of liposuction and inject that fat back into your joint that's having a lot of arthritis for several $1,000s. All right, so now we're getting to the cases. I think after the first case, we'll have some time for Q&A. So please submit your questions if any have come up so far. All right, so our first case is finger pain. Okay, so we have a 46-year-old male who is working in a wood shop. He has no past medical history, and he sustained an injury. He cut his finger with a table saw. He said he had no other injuries. He didn't hit his head. He didn't fall down. Only one finger was cut. This is the first time he's had it happen. He's not taking any medications. Now, he says his tetanus is up to date. Now, why do I say tetanus shot is up to date? So many of you hopefully have your tetanus shot. Tetanus is a bacteria, or Clostridium tetani is a bacteria that lives out in the world. And it can cause very severe pathology if it gets into your bloodstream and infects you. So kind of anyone with a dirty injury, we always make sure that their tetanus is up to date. You're supposed to update it every 10 years. Some literature for very dirty wounds, they require you to update it every 5 years. It can cause a lot of muscle spasms, lockjaw. So every time someone comes in with any sort of penetrating injury, we want to make sure their tetanus is up to date. And he had no other injuries, kind of what goes saying. And this is a picture of his hand. As you can see, the hand is bloodied. Only one finger is injured. Just going into some brief anatomy. So the farthest crease on the finger is called the DIP, or the distal interphalangeal joint. And then the next crease is the PIP, or the proximal interphalangeal joint. Proximal meaning closer to the body, and distal meaning farther from the body. And then interphalangeal, so between the phalanges. So your finger is made up of 3 phalanges. Unless you have a thumb, then that is only 2 phalanges. So he has a cut at the distal interphalangeal joint. This is, I guess, slightly higher. It was bleeding a lot initially, but now the bleeding is controlled. So we got an x-ray for him. This is actually not his x-ray, because this one goes to, like I was saying, the proximal interphalangeal joint, not the distal. But you want to get an x-ray to make sure that there's no, let's say, pieces of metal still on his finger. And you want to see, sometimes it's hard to see if there's any actual bone fractured by just looking at it. And if there's a fracture, that kind of increases their chance of having a bad infection. Now, having an infection is still increased because the skin is opened. But if it's a fractured joint and it's open, then that could lead to even worse outcomes. Now, what do we do for this? Now, how do you manage a finger amputation? So I've met some people who have amputated their finger and they're very comfortable and they don't need any pain medication. But some people are screaming in pain, which is very understandable. I probably would scream in pain if my finger was amputated. Now, we can offer a digital block, which is I'll go into in a minute or so. But that is a block to the nerves, or sorry, that is an anesthetic block that you inject actually near the nerves of the finger to provide anesthesia and pain control. We want to make sure the tetanus is up to date for the reasons that I mentioned before. Again, antibiotics, you can start it either in the emergency room, or you can start it, they can take pills when they get home. Make sure you consult your hand specialist. That could be a plastic surgeon or even orthopedic surgeon, whoever is covering your hand surgery consults at this time. And now, how do we transport the finger? Now, this is for you guys and to take it back with you out into the world if you ever experience an amputation, or if you ever meet someone who has amputated something, because patients just don't know, they just kind of go off what they see on TV. So I cut off my finger, what do I do with it? I'll bring it in a plastic bag, I'll put it on ice, or I'll put it in my pocket. I don't know what to do with it. So if you're transporting a finger or a digit or an arm or a leg, you want to make sure you put it on ice, but don't put it directly onto the ice because that may cause actually frostbite. So you want to make sure you wrap it in wet gauze. Try saline if you have it, but water is fine. And then place it on the ice and then into a plastic bag. Now, how long does the limb or finger last? So it's actually a little bit of opposite of what you would think. So actually the smaller limbs can last a little bit longer because they require less oxygen to maintain tissue viability. And if it's a larger limb, like an arm or leg, that needs to be reattached a lot sooner because within just 12 hours, 6 hours, if you're not putting it on ice, that'll start causing tissue ischemia a lot sooner and half the time. So 24 hours for a digit on ice, 12 hours for a larger extremity, 12 hours for a digit that's not on ice, and then 6 hours without and a larger limb. This kind of again goes into what I was just talking about. Make sure you wash the digits just because obviously tetanus or any other bacteria out in the world could be on there. Probably it just look nice. It's a dirty finger. Wrap it in the gauze, place it in the bag, place it on ice. And this goes into the digital block. So it's going to be 3 injections, or you could do it in 1 injection. I don't have that picture on here, but the first 2 injections are on the side of the fingers, and then the next one on top connects them together, and that'll numb pretty much the whole finger. Now the fingernails, a lot of times they're innervated by the nerves below the hand or on the palmar aspect. So you can inject the flexor tendon. So the tendon that makes your fingers kind of flex, you can inject the sheath of that tendon. You can't inject into the tendon itself, or you may cause it to rip or rupture. But if you inject into the sheath so that the anesthetic travels along the tendon, that can cause the finger to go numb just with that 1 injection. So sometimes I'll do all 4 injections if it's a really bad injury, especially nail injuries. Those ones kind of I experience a lot of the actual patient's pain when I'm doing a nail injury. So I'll want to make sure they're really numb before I remove the nail or repair any laceration underneath a nail or near a nail. All right, our first Q&A.
I just want to start off by asking, so when you were doing this procedure, where are you? Like, are you you're not in the emergency room, are you? Or are you at your clinic? Does someone come to you, or do you do it like on the spot?
If someone has an amputation?
Yeah.
So that's usually in the emergency room. I'll be doing this. Yeah.
And then some of the questions that we have are, so what influenced you to pursue clinical orthopedics versus surgery?
I don't like surgery. I have too much ADD and I can't stare at a surgical field for so long. And then a lot of times surgeons will be kind of on call. I don't really do call. So in the clinic, I'm there, and I guess technically there could be complications to an injection that I do. But usually surgeons, like, they operate on someone and they go home. But if anything happens with the operation, you have to get called in. And then sometimes orthopedic surgeons will take call at a hospital that they do surgeries at. So those are kind of 2 reasons that I didn't want to do this.
Yeah, I agree. I'm kind of the same way. So for somebody who's trying to pursue being a sports medicine physician for a professional sports team, do you think that any particular residency would be better, or special certifications to maximize chances for those kinds of jobs?
So I think it's 2 things. So if you want to be a sideline physician, or do you want to be the actual team physician where you're like with the team all the time and on call for them and traveling to all the games? Those are kind of 2 different things. The sideline physician only gets called for the games. Sometimes they travel to the games, but there are a lot of different time commitments. I think either pathway, it's kind of about who you know. It really, some hospitals do cater to professional teams. So if you have a residency that has a doc that's already with a professional team, I'm not saying they can get you in, but I'm sure that helps better than not knowing anybody. So like Stanford used to take care of the Golden State Warriors, and they were bought out by Kaiser because it's always about money. I know the doc at Georgetown, who's the doctor for the Capitals, but honestly, I don't think there's any real don't think your residency or even your fellowship kind of really matters. It's just about who you know in those situations.
Okay, and then do you work with PAs, and how would you say that the PA route differs in sports medicine versus like an MDDO? Like what can they do versus what can you do?
A PA in sports medicine. So there are there are PAs in orthopedic surgery. I don't want to say there aren't any, but I haven't met a PA in non-operative orthopedics. So a PAs that I've met in orthopedic surgery kind of function like residents. So they will see patients for the surgeon and kind of start treatment plans and kind of maybe schedule them for surgery and report back to the attending physician but they're not really carrying their own patients. They may assist in the surgeries as well. A lot of times they do, but they've kind of functioned more like residents. So they will work in a hospital system and they will be kind of on call as well and work with the attending physicians. Now in non-operative, I really haven't seen any. Doesn't mean it's not possible, but I wouldn't be seeing a PA adding to my practice. I feel like they should be doing more. I wouldn't utilize them to their fullest extent because they're like a master's degree. Now, maybe I would use like an athletic trainer, or a physical therapist in the clinic, but I guess maybe we could split the patients. They could see patients with me, maybe do injections with me. I just haven't seen that personally.
Hey, Dustin, this is Ray. Let me butt in.
Yeah,
it was interesting that you picked a distal interphalangeal joint amputation as opposed to a proximal. Can you comment about finger reimplantations and at what point on the finger you might reimplant versus when it's too far out to reimplant? Do you mind commenting?
Yeah. So I would say a lot of times the distal is not reimplanted. Again, it's surgeon dependent. It also depends on time, but let's say they bring it in at a certain amount of hours and you have to weigh in a lot of factors to reimplanting it, patient function, and then will the actual digit to actually take. So it doesn't really have to neurologically take, but the blood flow has to be there. So you can attach anything. You can attach anything to anyone. Will the blood flow be there, and will that finger become black and fall off later? You don't know, but the more distal it is, the more likely it is to not take. So I would say probably a more proximal injury, they are more likely to reattach versus a more distal injury. Because I feel like I don't know if I would say rejection, but it won't be viable in the sense that it'll just kind of fall off. So, and it's not really taking away a lot of their function. So kind of risk versus benefit, they probably wouldn't put it back on if it's just a distal injury.
So you've got about 250 people listening to you right now. What advice would you give if they're out camping or at a sports thing or working somewhere and they have someone with an amputation? What specifically should they do with the amputated part? You mentioned it, but would you mind mentioning it again?
Of course. So with the amputated part, you want to make sure you put it on ice, but try not to put it directly onto ice. Make sure you wrap it in wet gauze so it's not contacting directly, which may cause frostbite if it is in contact directly, and then transport it to the hospital with you. The actual digit, the hand or limb, like you want to make sure you control the bleeding, maybe apply a tourniquet or wash it as well. I would try to get there as soon as possible. Again, you could briefly talk about even teeth, because people lose teeth, and when I was mentioning hockey, that could be teeth as well. That can be stored in, this is totally tangent, but that can be stored in milk, or it can be stored in actually your own saliva too. Those are good for transporting teeth.
Dustin, we had a follow-up question, which was, why do you put it on moist gauze rather than dry gauze?
Oh, that's a good question. I feel like it'll just keep it from drying out like a raisin. You don't want to reattach a raisin. You want to attach something that's, is hydrated, I guess. It's just.
Yeah, I would think that a piece of dry gauze might wick moisture away from the amputated part, whereas the moistened gauze would keep that from happening.
I can see that happening. Yeah.
Okay, Taylor, take it away.
Okay, and then we have another question. It's kind of interesting. So, have you seen cases where some patients injure themselves on purpose for the purpose of getting pills or painkillers?
Uh,
Like, I guess maybe because you can't really fake it in person.
yeah. Um, I don't know if I've seen injuries to themselves on purpose, but you could have something going on and you could kind of sell it or upsell it. I've seen a few concussions. They're not really, this is a little separate, but I've seen people have like a few concussions that seem to be a little bit prolonged, and they can last for a long time. But I feel like they were kind of selling it because they didn't want to do their sport anymore, and they were blaming their injury for that, which is, totally understandable. People leave sports all the time. You see a lot of people with chronic pain in orthopedics and in medicine in general, and it's really hard to tell the difference between someone who's actually in pain and not in pain. And you try to take it a lot at face value, but I haven't seen someone go to the extent of hurting themselves for pain medication. But good.
And then I guess like, going along with that, so you probably work with a lot of students, and I guess you probably have to do like doctor's notes. You ever have students who are trying to like get you to write notes so they can be out of school for longer periods of time? Or
yeah, I do have to do that sometimes. Usually if it's a period that I'm uncomfortable with, I really want to make sure that we are addressing, because I want to make sure I want to believe everybody. So if someone's having prolonged symptoms and they don't think they can go back to school or athletics, what are we missing? Is this real or is this not real? There's nothing more psychological going on. That is probably, you want to make sure, take a step back. What are we missing? You don't want to keep your blinders on. Like, is this the only thing that's going on? Because patients will be honest with you a lot of the time, as long as you're honest with them. So you want to say, hey, are you just trying to get out of school? Because, this isn't the way to do it. Or, maybe I'll give you a few extra days, but we really need to get you back. Like, because we don't want you to fall behind. You want to really break it down for them. But that's an interesting concept.
Gotcha, that makes sense. And then I guess something random, kind of related to the students and whatnot. Do you ever have to treat like fans or people in the stands?
Yes, actually, yes. That's a lot of the residents here in this program actually will, prior to COVID, would work at basketball and hockey games and treat the fans. People will like to get drunk or fall or get sick. So that they definitely need treatment as well. You are the doctor there for anybody and everybody. I've had a couple lacerations, people like falling on the stairs of the stadium. So like, just make sure you watch where you're going when you're in those walking down those stadium steps. Nothing too serious, but yeah, you definitely, being actually a physician in general, especially an emergency medicine physician, you're kind of on call everywhere you go, on a plane, in a restaurant, in Whole Foods. Like, you got to be ready for anything and everything.
Okay, Dr. Ballard, do you have any other questions before we move on?
No, Dustin. Dustin, this is terrific. Thanks so much, and rock and roll.
Coolio. All right, let's go on. A couple more cases. All right, knee laceration. But a 20-year-old female, unfortunately, that was not a female leg, but 20-year-old female, no past medical history, sustained a knee laceration. She was riding bikes, and her younger child tried to kind of ram her a little bit, and she fell and kind of scraped her knee, which led to a laceration on her knee. She was wearing her helmet. She didn't hit her head. She didn't lose consciousness. So you don't have to worry about any concussion or traumatic brain injuries. Again, her tetanus is up to date. And this is some brief anatomy on the knee. So the knee is a hinge joint with maybe a slightly not hinged, but so you have your top bone, which is your femur, and your bottom bone, which is your tibia, and you also have your fibula, which doesn't articulate with either of those. It does hinge, like open and close, but there is a slight twist right when you get to full extension, which you don't really need to know about. And you also have your patella. Don't want to forget about that. All this kind of purple stuff is the cartilage, and this is more your meniscal areas. Many of you probably have heard of tearing your meniscus. You have multiple ligaments, all which can be torn. This doesn't include the muscles, but you have a lot of muscles attaching there as well. One thing I do want to bring your attention to are the bursa. Now, what is a bursa? So you have bursa all over your body. They're normal. They kind of help prevent a lot of rubbing between different structures on your body. And because they're preventing the rubbing, they are sustaining a lot of the actual biomechanical forces. So they themselves can get inflamed or even infected. So you have multiple bursa in your knee, some you can feel. The one I want to bring your attention to is actually the suprapatellar bursa. So this picture isn't perfect because actually this bursa does communicate with the actual joint itself. So that'll be an important thing later. Now, what's on our physical exam? So she sustained a 7-centimeter laceration over the superior part of the patella, right by the suprapatellar bursa. You see some muscles and tendon. The bleeding is slow. It's not pumping out. So whenever you see anyone who's having any bleeding, you want to make sure it's not an arterial bleed because they can lose blood very fast. And if it is an arterial bleed, you want to make sure you apply pressure or a tourniquet. And then their distal pulses are intact. So anyone with any extremity injury, you want to make sure that their sensation and pulse are intact, because if there isn't a pulse, then the tissue is not getting oxygen or blood. And then if there isn't any sensation, the nerve may be injured or compressed. And then sometimes that sensation does not come back. So those are true emergencies. But for her pulse and the sensation were okay. We got an x-ray on her. X-ray looks okay. This is only a soft tissue injury. The bones are not affected. She did not sustain any fractures. Now, do you get a CT scan? I'll go into that in 1 second. So this is called a traumatic arthrotomy. How do we manage it? So the joint is exposed. You're worried about the joint being exposed because you have a laceration with a part of the knee that communicates with the joint, and it's open to everything. The bacteria on your skin, the bacteria that was on the road that she was biking on, it could be anything. So you want to make sure this patient's going to need antibiotics. Now you're going to want to talk to your orthopedic surgeons because they may need, with this high risk of infection, they may need to have what's called a washout. So how do we find out, is the actual laceration intact with the joint? Do they communicate with each other? So we can do a joint loading test. So what we're going to do is we're going to put a needle into the joint itself, and we're going to fill it up as much as we can, either with saline, which is like salt water, or methylene blue, which has a bluish dye to it. You can sometimes load up to 200 cc's and see, does that fluid come out of the laceration? And that's kind of a poor man's test to figure out, is the laceration communicating with the actual joint itself? There have been some studies now saying that CT scans can give you this information without loading the joint, because putting all that fluid into the joint can cause a lot of pain. And sometimes, let's say you don't see any fluid coming out of the joint. That doesn't mean that there isn't a communication, which is what it means when I say low sensitivity, which means if the test is negative, you can't always trust that. So CT scans are becoming more common for these injuries. And then this patient will likely need IV antibiotics if there is an open joint injury and may need to go to surgery with orthopedic surgery for a washout, which they will probably open up the joint and make sure it's all cleaned and put fluid in it, and then suck that fluid out, and then make sure the patient gets antibiotics and close monitor.
Hey, Dustin, can you comment? Excuse me. What's the big deal about if somebody punches into the joint versus just cutting their skin? Why is it a big deal if they punch into the joint?
So it's for a couple of reasons. One, the joint is, it's very hard to get antibiotics to any deep structures, including the joint. So that's why they'll likely need IV antibiotics instead of going home on oral antibiotics. And also, if there's an infection in the joint and it goes untreated, you could lose that joint, and that could make you very sick and even septic. So that's an infection that we don't want to miss in the emergency room or in the sports medicine clinic. So that needs to go to the hospital right away.
Thanks.
Great question. All right, case 3, we're going to go into some leg pain. Sorry. All right. Okay, leg pain. So we have a 50-year-old male, had a recent tibia and fibula fracture. Those are the lower bones in your left or right leg, hopefully in both legs. He had a fracture recently, and he's having a lot of pain in his leg. Now, the fracture happened 1 day ago. He was out hiking. He tripped down kind of a little steep path that involved some rocks, and he heard cracks in his bones. He didn't see anybody. He kind of did the technique where you take some 2 sticks and you wrap your leg up with some leaves, and he kind of made his own splint, and he thought he'd be fine. He said he could walk on it with some pain, so he wasn't really worried about it. But today he woke up in significant pain. He's in the emergency room. He's crying out, asking for pain medication, saying his leg is just 10 out of 10 pain, 20 out of 10 pain, and he can't take it any longer. What's on your exam? So you're looking at the leg. It's very tense. The skin is taut. The bones didn't go through the leg, but you can look at it, and compared to the other side, it looks, I wouldn't say swollen, but it just almost like it's about to explode. And again, like I was saying, anybody with any extremity injury, you want to make sure you assess the pulses as well as the sensation. And his pulses, his distal tibial, his posterior tibial pulse, and his PT, posterior tibialis pulse, and his DP, his dorsalis pedis pulses are very weak, and you feel those on the ankle. And sensation, you're feeling his foot, and you think maybe because he's on a lot of pain that he can't really pay attention to you touching his foot, but he's saying that it definitely feels different than the other side when you're touching his feet. An X-ray, so this is the tibia, and fibula. This is an anterior view and then a lateral view. So you see comminuted fractures with multiple pieces. They are displaced. They're not in line anymore. So this person definitely needs to have the bones realigned. They may need surgery, but that is not, he's in a little bit too much pain from just a fracture, and that wouldn't explain why is he having decreased pulses and why does he have decreased sensation to his distal leg. This is called compartment syndrome. This is an emergency. So there's bleeding and inflammation from the bone. So bones produce blood. You can actually put an IV or a intravenous line into a bone. It's called an IO or intraosseous line. We drill the needle into the bone, and that can be, you can give fluids, you can give medications because the bones produce blood. And so there's a lot of blood, and because there's injuries to not just the bone, probably the muscles. There's a lot of inflammation in that area, but it has nowhere to go. So other things that can cause a compartment syndrome, just so you know. So this guy was hiking, so maybe he was bitten by a snake. Sometimes burns can cause a lot of inflammation and swelling in the compartments of the leg or the arm. Crush injuries, so bad car accidents or workplace injuries where something fell on you. Again, that can cause breaks in the bone, injuries to the muscle, a lot of inflammation, a lot of bleeding, and again, just there's a lot of swelling in the compartment. And as it gets bigger and bigger and bigger, you'll see that it can cause compression of the nerves, which leads to paresthesias, compression of the artery, which leads to pulselessness. Again, motor nerves being compressed, that can lead to paralysis. When there is decreased blood flow, that can cause the limb to go cold. That's called poikilothermia. And then again, pain, pain, pain. So you want to remember the 6 P's of compartment syndrome. So how do we diagnose this? So you can diagnose it based on looking at him and saying, that guy's in a lot of pain. He can't feel me touching him. I can't feel a pulse. I think he has compartment syndrome. But how do we objectively say this guy has it? So you want to make sure you check the compartment pressures. And I'll show, there'll be a picture in the next slide, but what's a normal pressure? So a normal pressure would be less than 20 millimeters of mercury, but the better way to measure it is actually comparing it to their own blood pressure. So you check their blood pressure and you check their compartment pressure. And if there's a difference between them that's less than 30, that's too high for the compartment, and that person has compartment syndrome. And then what's the treatment? A fasciotomy, which I'll show you in a second. So this is the lower extremity. You're kind of looking at it from the top down. This is your tibia and this is your fibula, and it has 4 different compartments. Almost every compartment contains nerves as well as blood vessels. And depending on where the fracture is, where they're having decreased sensation, where they're having decreased blood flow, that kind of tells you which compartment is swelling and causing the compartment syndrome. Now, could multiple compartments be injured? Definitely. But you want it, this is a good way to kind of throw in your physical exam skills. Okay, they can't feel me touching them on their lateral leg. Okay, I'm concerned about the peroneal nerve. Or they can't feel the artery that's connected to the dorsalis pedis or the posterior tibialis. Okay, I'm worried about this compartment. So this is good to always remember your anatomy when going and looking at compartment syndrome, or just in general. This is how you check compartment pressure. So this is one of the commercially made devices that you place. First you calibrate it, and then you place a needle directly into the compartment, and it'll read out a pressure for you. And then either you can take that pressure at, oh, it's over 20, they have compartment syndrome, or they sometimes, like let's say 15 or 17, but their blood pressure is kind of low, then you're worried about that. That is a better test actually for compartment syndrome compared to their actual blood pressure. And this is a fasciotomy. So when something's swelling and it has nowhere to go, well, you got to give it somewhere to go. So you actually cut open the leg at the compartment that's swelling that you're concerned about, and you want to kind of release the tension. Now, you can perform these all over the body. So you can get compartment syndrome in your legs, in your arms. You can actually get it in your torso, especially from bad burn injuries. You can perform a fasciotomy on the chest or stomach in bad emergencies. But the treatment for this patient is fasciotomy. Let the leg decompress, let the inflammation kind of subside, the bleeding subside, maybe fix the fractures, and then hopefully this will all get better. But once it's decompressed, you should regain blood flow, as well as regain sensation and prevent any further injury or distal ischemia.
Dustin, do you open every muscle that's involved?
You would want to open the specific compartment if you can, but sometimes you don't have time. So you'll want to just cut open all of them just to release the whole thing, because the more cuts, the more swelling that can be allowed. You can't really get back bad, sometimes tissue ischemia. So sometimes it's safest to just cut open and let the leg, because you can always repair the lacerations later after the inflammation is done. A cut to a muscle is not going to be the end of the world, but if there isn't blood flow to your foot or sensation, then that could lead to bad outcomes later in life or later that day. So sometimes the best thing to do is just cut open the compartments and let the specialist take them to the operating room, actually. Case 4, shortness of breath. So this one's a little different. So this patient comes in, I know this is an orthopedics talk. Well, you'll see. So shortness of breath. So we have a 33-year-old male, no medical history. Oh, sorry, he had a fracture, maybe a few, in the last several days. He actually came to the emergency department. He had a femur fracture. He went to the operating room. He had an ORIF, which is a open reduction and internal fixation. So they open up the leg, they place a pin in it or a rod to stabilize the fracture. And then they, after you're all stabilized, then they can discharge you home. And he's now having some shortness of breath. Otherwise, he doesn't have any cardiac history, he doesn't have any lung history. So you're kind of wondering, did this surgery do something to him? Did they, injure a nerve, or did the anesthesia, did that cause him to have shortness of breath? Who knows? So he noticed a new rash, which looks kind of like this. So this is kind of called petechiae, kind of a erythematous papular rash on the body. It usually blanches because of the blood flow to them. It shouldn't be like a raised rash. His oxygen saturations are dropping. They're about 86%, and his heart rate's beating very fast. So what are we concerned about? X-ray looks fine, so didn't get a pneumonia, didn't drop a lung or have a pneumothorax, collapsed lung after this surgery. Heart looks okay, doesn't look enlarged, which would you be concerned about fluid around the heart or a new heart failure. Doesn't see like there's any stenosis of the airway and the trachea up top, but chest X-ray didn't really give us too much information. Now, this is a classic example of a fat embolism. So when a bone is broken, not only does it release blood and cause inflammation, but it also can release fat globules. And those globules can get into the bloodstream, and they can go to your lung and cause shortness of breath, as well as lung injury and decreased oxygenation. So how do we treat it? Unfortunately, there is no magic bullet. Usually when someone gets an embolism from a blood clot, that can be treated with blood thinners, but this fat embolism does not really respond to that. So unfortunately, you have to just make sure they kind of get through it by giving them oxygen, making sure they're monitored closely before anything bad happens, because you don't want them going home and getting less oxygen and their brain gets ischemia or something like that. So usually it'll kind of pass on its own. It'll kind of dissolve as time goes on, but you want to make sure you keep their oxygen up, make sure they're safe, and that they're not having any other complications to the surgery that they recently had. And our last case is finger pain, part 2. We have a 41-year-old male. He is a painter, and he's having some finger pain. But what happened? So he has this paint gun, kind of a high pressure gun that sprays paint over the houses that he's painting. And he accidentally was handling the gun, and he kind of injected his finger, and he got a little puncture wound. It's kind of a little bit painful, but kind of just want to get checked out. This is what it looks like. So not too bad. Maybe a little bit of bleeding, kind of tender, but maybe just put like a Band-Aid on it. I think we just call it a day, send him home. Don't give him like a big ER bill. Wrong. So this is the X-ray. So that is all paint material that is in his hand that he injected through his finger. So this is a significant emergency because it can lead to this. So because of the high pressure of the gun, it can travel along the fascial planes very fast. And initially you don't really notice anything, but that foreign material in your body can cause significant inflammation and infection. And this needs to be treated seriously and immediately right away. So it's called a high pressure injection injury. It needs to go surgery right away. It can occur from grease guns, paint guns, or any type of fuel guns. A lot of times mechanics will get this when they're handling their tools in the garage. Again, it can cause a large inflammatory response. Make sure that tetanus is up to date, very important. And again, it can cause inflammation and infection. So you want to make sure you treat them with antibiotics, especially prior to going to surgery.
Hey, Dustin, a good question just came up. Why did the high pressure paint gun, what was the deal about it injecting stuff in there? I mean, why is that a problem? I saw the X-ray with the paint, but what's that got to do with this high pressure paint gun?
So if someone just had because the guns were made to spray paint all over the house. There's commercials where you just take one swipe and all the paint goes through it, but it wasn't made to go into people's hands. So there's so much PSI or pressure behind that paint that its nozzle is very tiny, and it goes into the finger, and it just goes along the path of least resistance and will travel along the fascial planes and go deep into your hand. And you may not even notice it right away because all they have is a small puncture injury, and it hasn't caused any inflammation or infection at that time. But you have to make sure you treat it very seriously, because it's not going to go anywhere. That paint's going to stay in your hand until you get surgery. So it's going to cause it.
So what's the problem with the paint, Dustin? Does it cause a problem?
Paint does not belong in your body. Whether it's ingested or injected to your finger, that paint, your body is going to have a huge reaction to that paint, and you could lose your hand or your arm if it's not treated immediately.
One important thing we learned early on about these is that, and you said it, but I just want to reiterate it, that the tendons that move your fingers, everybody make a grip on your hands right now, all 230 of you, just grip your hands right now. Those are tendons moving in very smooth sheaths. These sheaths are made of very delicate tissue. And when you inject paint all up in there, it flows all the way up through the sheaths until it runs out of paint. And as Dustin was saying, that the area becomes terribly inflamed. The term is necrotic, the tissue dies. And so you literally, Dustin, show that picture of having to carve the patient open again. A couple of, yeah, right there. You got to go in there, and the term is fillet. You got to go in there and cut open every sheath and bit by bit pick that paint out. And it's a terrible problem. Yeah, Brianna says fillet, but it is. I mean, it's cut wide open. You got to go in those tendon sheaths, and the problem is just devastating.
Yeah.
So for all the listeners, is it more likely that the dominant hand or the non-dominant hand becomes injured in a high pressure paint gun injury? Y'all put it in the chat real quick so Dr. Harris can see. All right. We've gotten a lot of non-dominants coming up. Dustin, explain why it's more likely that the non-dominant gets hurt.
Let's say the patient is right-handed, so he likely is spraying the house with his right hand. And so he's likely holding it in his right or dominant hand. And maybe he's cleaning it with the other hand or just kind of handling it. And so he's likely to inject his non-dominant hand with the paint.
And the other thing I found over these many years is that people get distracted. They'll actually be using a dangerous device that they've used for hundreds or even thousands of hours, and they just get distracted. Somebody tells them a joke, they look the other way, and bam, they've squirted paint all the way up their forearm. So, all right. Taylor, you want to, was that it? I think I saw a VN slide, Dustin.
I got,
All right. So Taylor, take it away with our next set of questions. We got a bunch of them.
I was just curious, how do you like prepare that person for okay, actually, never mind. So what about someone who, is not likely to go into the emergency room? They're like, it's fine. I didn't hurt myself. I don't see anything. I don't have any pain. Like, do eventually they have like excruciating pain where they'd probably come to the hospital when it get like really hard? Like,
yeah, it's almost like also a compartment syndrome where it'll be severe pain. The swelling has nowhere to go. So your hand or arm will become very taut. It may even rip open on its own, unfortunately. But yeah, I hope they'll come eventually, but they should know that almost immediately they should come. They should know like something bad is about to happen. So I need to go to the emergency room right now.
Because if I got pain in my hand, I guess I wouldn't think about it. But now that I know, I guess if I'm using a super high pressure paint gun, I probably now I know.
So Dustin, after all the paint's removed, how does the healing process start after that with all that damage?
So they can do, with all the paint being removed and the washouts, definitely started them on antibiotics. Sometimes they'll do wound vacs on the hand or arm, which many people out there may not know, but they'll try to bring the tissues together with literally a vacuum and put kind of pseudo tissue within there and slowly bring the tissues back together. They may need prosthetics or skin grafts after that. Depends kind of what other injuries they have had. Is there a lot of muscle injury, nerve injury? Could be a very devastating, as that picture shows, a very devastating injury as well.
Or my cat's like scratching in the background. So how often or how many shots is best for opium steroid shots? Dr. Fowler put this question in the chat, I believe, and I'm kind of worded. I guess, how many is best for opium steroid shot benefit, say for plantar fasciitis? Dr. Fowler, can you clarify?
How many steroid shots can you get a year, maybe?
I don't know.
Yes, that's correct. Really, what do you do about steroid shots? Is it a general thing that you stick them in the butt with some Decadron, or is it you inject specifically into the painful area?
Yeah.
And follow up, if you stick a needle in a tendon, doesn't that cause a problem with the needle in the tendon?
So when you first steroid injections, they kind of recommend up to 4 a year, or 1 every 3 months, and try not to go over that. Probably a shot in the butt would help anybody, but it would probably be better at the site. So I usually try to go into the site. When you're injecting tendon or ligaments, I use it under ultrasound so I don't go into the tendon, which could easily cause a rupture. Plantar fasciitis is one of the ones where I would try to recommend the platelet-rich plasma because that an incorrect injection or too many injections in that kind of very taut ligamentous area that can cause a rupture in that area too. But I've done steroid injections there as well. But I probably wouldn't do for a year. Again, what is the underlying problem? These aren't fixing the issues. So what is the, what kind of different shoes can we get them? Different type of biomechanical issues, that kind of stuff. You want to find out why are they getting 4 injections a year rather than just keep injecting them forever.
Well, Dustin, let me see if I understand you. So what you're saying is that when someone comes in, let's say they have plantar fasciitis, chronic inflammation of the tendons on the base of the foot, which can be really disabling. You're saying that don't just go after it with steroids, try to find the cause of the problem, like inappropriate shoes and so forth. Could you follow up on that just a little bit?
Yeah, specifically plantar fasciitis, usually the most common cause is tight heel cords or calf tightness. So even just like basic stretching exercises or eccentric exercises with the Achilles tendon can help with that. We recommend heel cupping or also proper shoes. But I could put steroid anywhere and make you feel better, but it's just going to come back over and over. So again, finding what the actual issue is, what do they do for work? What kind of shoes they wear at work? It could be a lot of things. So sports medicine, one of the good, so emergency room, you kind of see a problem, you try to fix it. If not, they're going to go out into the world and either go back to the ER or follow up with their doctor. Sports medicine, I see them over multiple visits and we can try different things, or I get to know them more about their life and seeing what kind of stimuli are causing these injuries. So that is a little bit better of a well-rounded perspective that I get on these patients, which is good.
Thanks, Dustin. Taylor, take it away.
Okay. And then going back to the fasciotomy. So when you're going to prepare someone, like when you're going to cut them, do you have to like give them a bunch of pain medications in the local area beforehand? And then like after you've cut them, because I'm assuming like it goes numb for a while, you don't feel it, and then it comes back and it's painful. And also like how long would you leave them open, and do you worry about them getting infected?
Yeah, great questions. So it kind of depends on the patient. So there are multiple ways to do procedures on patients in the emergency room or in orthopedics. So that kind of procedure may need actually to put the patient to sleep so they don't, scream out in pain. You could do nerve blocks in the upper or lower extremities. Those are becoming very popular. So you could numb the whole leg by injecting some numbing medication around a nerve. You could even start a drip that continuously gives medication to that nerve area. But this is a pretty painful procedure. So the patient may need to be given some sedative medications that kind of puts them in more of a twilight while you do the procedure. They may also go to the operating room and they'll just be intubated under anesthesia and they get that procedure as well. It just depends kind of what resources you have, how much time you have. Like, do they have no more pulse? Or are they just in a lot of pain and you're worried about them progressing to worse off compartment syndrome? How long do you leave that open? It's hard to tell. It depends on the patient and how bad the injury is. And then they also probably will be closed with what I was mentioning before. So either a skin graft or what's called a wound vac, where you kind of put sometimes foam, but also artificial tissue within that area. And then you cover it all up and then you apply suction to it. And then slowly, as inflammation goes down, the tissues come back closer and closer together. And they can go home with that too, as long as they learn how to change out the dressings on their own at home. So it could close over months, depending.
A lot to think about, I guess, when you're doing that. That'd be scary. Yeah. For both the patient and you, I guess. So someone wants to know, why do fractures increase the risk of infection?
Again, the blood flow and also poor healing. So getting the antibiotics to that area, getting oral antibiotics to that area is more difficult than just getting it to maybe like a skin infection or like pneumonia or something like that. But because the bone is broken and the bacteria have a more direct route to the intermedullary bone area, that can cause just a more serious infection. And sometimes it's a little more resistant to antibiotics. certain antibiotics.
And then I guess like if you're standing on the sidelines, you're working for a team, how would you handle, like, for example, I know somebody whose brother he's on a football team, and he like collapsed and had like a heart palpitation or had a heart issue in the middle of the game and like kind of dropped down. Like how do you approach that kind of situation? Because you're looking more so for injuries, but like what do you do, I guess?
So every game I go to, I make sure I know where the closest AED or defibrillator is. And a lot of times they can measure or analyze the rhythm that the patient's in. So if someone drops to the ground, first thing I do, ABC, or first thing I feel is their pulse. So if there's a pulse and he's just having palpitations, then okay, then I have some time to think. But if there's no pulse, then they need to start CPR right away. And then you get the closest defibrillator, which in a lot of stadiums are fairly close by. A lot of games, they'll have EMTs at the games, which is very helpful, and they'll have their defibrillators there as well. So it's actually kind of interesting because I'll talk to my residents when they're at the game with me that you'll actually removing padding on a football player can be very difficult. So anyone with a severe head injury or neck injury, actually keeping them in the football gear is helpful, because you take the football helmet off, they're still in their shoulder pads, the head drops down. If you take the pads off and then keep the helmet on, now the head is above the body. So you kind of want to keep them in that, but remove the face mask, which can be removed with a screwdriver, which usually the trainers will have a electric screwdriver, or sometimes they'll have just a special tool that will just like pop, 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 and pop the face mask off, so you have access to the airway and make sure the patient's breathing properly. But yeah, that's a good question. It's hard if they don't have an injury, they weren't hit by anybody and they just dropped to the ground. I guess that could be my differential changes when I didn't see them get hit. But it could still be a brain injury, or it could be collapsed lung, or it could be a heart thing. But probably the heart thing is the thing I can fix the best, or try to fix the best at the sideline. But I got to make sure I know where the defibrillator is.
Okay, and then I'm assuming you probably deal with a lot of people who have ACL tears. How do you approach that kind of situation, and how long is the rehab process? What does that really mean for somebody to have an ACL tear?
So ACL tears aren't, I guess it depends what kind of level the person's at. So first, on the sideline, there's not much you can do about an ACL tear. In the clinic, sometimes you can drain the fluid because there can be a lot of bleeding if that's causing a lot of pain or inflammation for the patient. A lot of surgeons these days will actually have the patient do physical therapy maybe prior to the surgery, because a lot of ACL tears, if you see a lot of them, you'll notice that the muscles will start to atrophy almost immediately, because I feel the body knows that you are injured, so it doesn't want you using that leg. So you can almost see like your rectus femoris or like your hip flexors already becoming smaller than the other side, maybe like a week or two after the injury has happened. You don't need an ACL to function in life, which is one thing about sports medicine that is kind of fun, because it's like, these are all frustrating annoyances, but they're not going to kill you. So having an ACL tear is, you don't need, I have a friend who skis without an ACL, but they wear a special like knee brace for it. So ACL tears, and then you can repair those with your own tendon. So it could be like a semitendinosis or patellar tendon, depends on which surgeon you're going to, or you can get a cadaver tendon as well. But I've had people have multiple ACL tears. They've torn their repairs, and but you don't need one. Just depends what kind of level you want to get back to. If you're like, oh man, I used to play basketball, but this is my sign, I'm going to stop playing basketball. But if you're like, I really need to get back to my sport, then yeah, you would do surgery probably as soon as possible. It's probably like a year until you get back. Some people, I see people push it to 6 months, but like that's a lot of rehab, and you're also at a higher risk of just re-injury if you go back too soon. So you have to, again, weigh the risks and benefits.
Gotcha.
Yeah, Dustin, that's a good point. Doing physical therapy will improve your rehab afterwards. We actually used to call that prehab. When you strengthen the muscles that you need, you can see people bounce back so much faster. Investing 2 to 4 weeks of some prehab can save you a couple months after surgery. And you may have some people like you said, they don't need an ACL. What are they going to do with it? But they still need that stability in their knee. And that's when you take advantage of knowing your anatomy really well. You can strengthen the hamstrings to replace the integrity of the ACL and some other tips and tricks like that. So appreciate Dr. Harris throwing the shout out to physical therapy. Y'all make sure to love on your PTs in the future. They do a lot for your patients.
Well, Taylor, pick your last and best question, and then we're going to let Dr. Harris get on to do his emergency medicine career.
Okay. I guess more on a personal level, you know, what do you think your favorite part of sports medicine is? And I guess just, yeah, what's your favorite part, or what do you love the most about it?
Great question. So my favorite part of sports medicine is that the people are usually active and they want to get back to their sport. They want to be active. They want to be healthy. And so they're going to do whatever it takes to get better. And they listen to you. A lot of times in the emergency room, people won't listen to you and you don't get that relationship. They don't trust you. But in sports medicine, I see them get better, and that's a great feeling. In the emergency room, I see them once and hopefully I don't see them again. But in the sports medicine, I'm like, oh, that injection really helped. Thanks, doc. And I'm, back to doing this, or, it's kind of getting better, but, not all the way there. Maybe a few more weeks of physical therapy and I'll be back to where I want to be. Like that can be very rewarding in certain cases. So that's something about sports medicine that I really missed when I went into ER. ER has other sides that are great, pieces that are great to it. And then sports medicine isn't perfect as well. But yeah, the patient population is different for sure. And they being young, active, treating some kids kind of keeps me young and makes me want to be active too. And then I get to diagnose myself with why I have knee pain and stuff like that. And then like when I was in fellowship, I hurt my thumb and my co-fellow injected my thumb with my own blood. So that was fun. And then I injected her hip because she was having some hip pain. So that was fun as well. I'll probably inject my dad because he has bad knees. So because, we're all active people and we want to stay active. So those are some of the reasons why I like sports medicine.
That's awesome. I like that answer. Dr. Fowler, do you have any last comments or anything?
Dustin, what a great talk. That was terrific. Thank you so much. It's so good to hear not only someone who is a member of a primary specialty, but who's allowed himself or herself to branch out into an adjoining and related specialty, and to be able to find, as all the folks listening tonight, that a single career is not necessarily all that you will necessarily do. This is what a fellowship after residency training can bring. So Dustin, we're so deeply grateful. You had literally 250 students sitting on the edge of their chairs tonight, just loving your talk. And so we are very, very grateful. We want to thank, let me ask everybody to put thank you, Dr. Harris, into the chat. And Dustin, take a look at the chat as these all, as a couple of hundred of these go roaring by for everybody to let you know just how very, very grateful we are that you took the time tonight to be able to share all these wonderful thoughts with us. Well, folks, this is virtual shadowing. This is talk number 67, and we're 15 months in. We want to thank you for coming every week. This is the admissions season, and so we are encouraged so far that admissions committees seem to be looking at virtual shadowing as not just an option, but as something that can assist in you getting your shadowing hours. So we welcome you to come back every week, and as long as you keep coming back, we will be here. We're applying for some grant funding now to help us cover the cost of the virtual shadowing program, and we're looking forward to hopefully getting some nonprofit support for that. So Taylor, do you want to tell them what's the word on how to do the exam?
Yes. Wait, if you could actually reshare your screen.
Oh yeah, sorry.
Screen. I think like the very last slide was the QR code for the quiz. And then we're also going to post it on our Instagram story for everybody who missed it here. But this is for assessment 67, and it'll be open until next week at 6:59. So just FYI.
Thank you all.
All right, everybody. Well, thank you all for coming. Dustin, once again, thank you for joining us. It means a great deal, and it's been part of a wonderful family that will continue. So everyone, this is Virtual Shadowing. We want to thank you for coming. We'll be here next week with another exciting session. And on behalf of the whole Virtual Shadowing team, we wish you a good evening and a good night.